Good afternoon, everyone. We really are thrilled to have you join us today. We were very excited to see so many of you interested to discuss this topic. You'll see we've named the webinar the How the One Big Beautiful Bill Act Will Impact Health Plans. We did kind of stick with that the formal technical name of the bill, and we kind of did that intentionally. We know there's some shorthanded names percolating, and we don't know which will be the one that will stick. I think OB3 was what we heard most recently, but we're going to hold out until we kind of find out if there is a shorthanded reference that's kind of formally adopted by the federal government and folks implementing the law. And meanwhile, we'll just stick with that traditional title, or you might hear folks during today refer to it as the Act. So we wanted to mention that, and then we can go ahead to the next slide. And I'd like to introduce you to the speakers that we have here today. I'll be speaking on and off throughout today's presentation, as will Catherine Bakich and Julia Zuckerman. Kathy is a senior vice president within Siegel's national health compliance practice and has over 30 years of experience on a range of health compliance topics, including all those we're going to talk about today. I joined Kathy nearly a decade ago and worked with her in partnership in the national health compliance practice as well. And Julia is a vice president and a senior consultant who works both on health and retirement compliance issues and has a lot of expertise on the topics that we'll be talking about today as well. So with that, I think we can go ahead and just take a quick peek at the agenda. We promised you and more, not just an update on budget and tax legislation that was enacted. So while we will spend a significant amount of the time digging in on what passed in the Act, we are also going to spend some time on some other updates, things that we've been watching, things that we think it's important for plan sponsors to continue to monitor and think about the implications of. So that includes some updates related to recent litigation and also kind of a little potpourri of other updates and topics that we continue to watch, and we'll provide that at the final segment of this presentation. And with that, I'm going to turn it over to Kathy to kick into the first topic.
Thank you, Elena, and welcome everyone. And I hope all are well, particularly thinking about folks in Hawaii and California who may be under various warnings. We hope everybody is okay and stays safe. If you go to the next slide, I'm going to spend some time talking about the law. As Elena mentioned, it is formally called the One Big Beautiful Bill Act. We don't know the nickname of it yet, but we're probably going to refer to it as the Act here. And the Act was signed by President Trump on July 4th of 2025. Next slide. We're going to talk about the employee benefit aspects of the law, but I just want to mention what's not in the Act. And it's very important for plan sponsors, and that's that there was no change to the taxation of group health benefits or retirement income benefits. A lot of us were worried that because of the need to fund the extraordinary expenditures in this bill, that Congress would take a look at the taxation of group health benefits and maybe modify them along the same lines of the so-called Cadillac tax back in 2010. Luckily, and probably due to very good lobbying, that none of those changes occurred in the Act. And so that's great news for us. On the other side, there was no extension of the enhanced subsidies for ACA marketplace coverage. And I'm going to talk about that a little bit later. And there was also no change to individual coverage health reimbursement arrangements. The House bill would have codified those rules in an attempt to create a way for employers to fund individual health insurance coverage, and that did not make it into the final bill. So the next slide. And just a moment on what we expect to see next. The next thing that happened after this bill passed was a rescissions package that passed and was signed on July 24th. That rescissions package was a unique piece of legislation because it was a presidential initiative to roll back expenditures, which means that things that were already appropriated by Congress and enacted were rolled back from the president so they didn't have to be implemented. It primarily focused on public television and radio and the Corporation for Public Broadcasting and foreign aid. After this, we're going to see a couple of new legislative efforts. We're going to see the appropriations efforts that have to be done by September 30th, or else there may need to be a continuing resolution after September 30th. So after the August recess, we expect to see a lot of activity around appropriations. And then technical corrections. Whenever there's a huge mega bill like the Act, you always make a few mistakes. So there may be a technical corrections bill that's really just correcting statutory language that was in error. So those are some of the things we're looking to see. Next slide. So getting into the benefits aspect of the law, health savings accounts is one of the areas where there were some changes. There were 3 changes that expand the use of HSAs that we're going to talk about. The permanent and retroactive extension of the provision allowing high deductible health plans to cover telehealth. The fact that bronze and catastrophic ACA exchange plans now qualify as high deductible health plans for HSAs, and the direct primary care service arrangements and the fact they don't bar HSA participation. So next slide. There were lots of things for HSAs that were not in the final act that passed. In the House bill, it had a wide range of changes that would have really significantly enhanced the attractiveness of health savings accounts. As you all know, if you're in a health savings account, you have to also be in a high deductible health plan, but you can't be in an other health plan. The law would have been changed to allow people to be in an HSA if they were enrolled in Medicare Part A, if they had access and used an on-site clinic, and if they were covered under a spouse's health flexible spending arrangement. However, none of those changes made it into the final bill. There were additional changes that were not included, including things like increasing HSA contributions for low-income folks, allowing HSAs to reimburse expenses 60 days before establishment of the HSA, allowing both spouses to make catch-up contributions to the same HSA, allowing HSAs to pay for qualified sport and fitness amounts, and allowing limited rollovers from HRAs and FSAs to HSAs. So none of that was in the final bill. However, we expect to see those kind of proposals coming up in the future. So with that, I'm going to turn it over to Elena to talk a little bit about the telehealth aspects of the bill.
Thanks, Kathy. So we had seen during the COVID pandemic that there was an expansion in flexibility related to high deductible health plans, and it basically enabled plans to cover telehealth services before a participant met their deductible. So that first dollar coverage really being available for telehealth benefits. But the way that COVID relief was initially structured and then extended did again expire at the end of 2024. So now we've seen that the Act permanently and retroactively extends that opportunity for that ability to use the high deductible health plan to offer coverage without the deductible having been met. And that goes back to starting for plan years beginning December 31, 2024. So really just opens up that flexibility. This is a plan sponsor choice, so plans can choose whether they want to permit the coverage for telehealth before the deductible is met or not. And then once they've made that decision, structure things accordingly. But this was a really favored flexibility, and so many plans may think about continuing to take advantage of this now that it is official and permanent. So you don't have to continue to watch to see if there's been extensions of the ability to do this. So that is the reform that was included. And I think I know now we're going to move into the next topic where we talk a little bit about direct primary care. But Kathy, maybe before we talk about what the Act did related to direct primary care, can we talk a little bit about what direct primary care is? And I know one of the questions that I hear a lot are people are wondering whether this is the same as when they hear that their doctor, for instance, offers a concierge services, things like that. So we've been getting a lot of questions about what that is before we even talk about what the Act did.
Yeah, and you can move to the next slide. The direct primary care service arrangement is kind of like a concierge arrangement. And the idea is that the primary care center or practice is setting up almost kind of a preferential or like a prime service where people that pay an extra fee can get easier access. They might be able to get access through email. They might be able to get preferential appointments. I know of one practice that has a special room, and the people that pay the fee can go into the separate room, which is a little nicer than the other rooms for the other patients. So what we're talking about here is like a concierge service. Sometimes those concierge services can charge $1,500, $2,000 a year. This is saying that you can have a direct primary care arrangement where you have those preferential services that you buy into a primary care practice, but the fees for that service cannot exceed $150 per month for individuals or $300 per month for more than one person. And the services that are provided by that primary care clinic can't include things that are beyond primary care, like general anesthesia, prescription drugs, lab services, and other things not typically administered in a primary care setting. So next slide. So what the law says is that a member can belong to a direct primary care service arrangement and still participate in an HSA HDHP. Now, this was not a question that we heard a lot because I don't think a lot of people thought that these kind of concierge arrangements were group health plans that would disqualify you from participating in an HDHP. But now we know that they won't. So if your participants sign up for a private care clinic, they can still be in an HDHP. In addition, the law said that the fees that the individual pays for membership in their direct primary care arrangement are medical expenses that can be reimbursed from an HSA. And this is effective for months beginning after December 31st of 2025. We've gotten a lot of questions about this provision and how broad it is. The provision only amended the HSA parts of the statute, and that's section 223. So it could be that the agencies will allow this to be used on a broader scale, but for right now, it really appears to apply to the HSAs only. So next slide. Another thing the bill did was to move forward various reforms related to fringe benefits. And here we're thinking about things like outside the core group health plan, like transportation and moving expense benefits. So Julia, can you tell us a little bit about some of these other fringe benefit changes?
Yes, thanks, Kathy. So as Kathy mentioned, the Act modifies a bunch of exclusions that for employer-provided fringe benefits, and these are all for tax years beginning after December 31st, 2025. So essentially for next calendar year. The first category, bicycle commuting expenses. So employees used to be able to exclude from their income the value of so-called qualified bicycle commuting benefits that are provided by their employer up to certain monthly limits. Now, you might not remember this exclusion because it hasn't been around for a while in effect. The Tax Cuts and Jobs Act, and that was in 2017, suspended the income exclusion through the end of 2025. And what the act here has done is terminates the exclusion permanently for qualified bicycle commuting reimbursement. So in other words, the suspension is permanent and that bicycle commuting reimbursements will not be tax-free going forward. For transportation benefits other than bicycle commuting, and there are quite a few of them, the Act adds an additional year of inflation adjustment. And although these reimbursements are taxable at the federal level, the ones that are no longer subject to the exclusion, you might want to keep in mind that state law can vary here, especially in states that have special commuting ordinances. So that's something to keep in mind as well. The Act also terminated the moving expenses reimbursement exclusion, except for in very specific circumstances. So the Act makes the suspension of the income exclusion for employer-provided moving expenses permanent, except for certain members of the armed forces and the intelligence community. And again, all of these are for tax years beginning in 2026. Next slide, please. So another employer-provided fringe benefit is an educational assistance payment. Current law allows a tax-free employer educational assistance payments up to $5,250 annually. This can be helpful for certain employers looking to assist their employees with continuing education, and can be a very valuable benefit to employees. The Act makes this exclusion permanent and also indexes that amount, the 5250 maximum exclusion for taxable years beginning in 2026. Next slide, please. Okay, so the DCAP. I think most folks who deal with childcare expenses are aware of this provision of the tax code. So under current law, the maximum exclusion for an employer-provided dependent care assistance program, a DCAP, which is also sometimes referred to as a dependent care FSA, even though that's not the technical term, that might be the term that you recognize it as. And this is Internal Revenue Code Section 129. The amount has been $5,000 for a while, $2,500 for a married individual filing separately. And the Act increases the exclusion to $7,500 annually, and that's $3,750 for married individuals filing separately, also effective for the next tax year. The Act also enhances the child and dependent tax credit. And that credit can be claimed as a credit against tax liability instead of an individual taking the DCAP exclusion. So it's either or there. And there are a couple of things to consider in thinking about these two provisions. So usually, not always, lower wage earners are going to benefit more from taking the tax credit, and a higher income earner will typically benefit more from the DCAP exclusion. That means that that can cause at times non-discrimination testing problems for the DCAP because it tends to be the favored and best option for higher income folks. So it's important that you consider non-discrimination testing for your DCAP every year. Taxation of tips and overtime. You might have heard about this. That has gotten a lot of publicity. This was something that Trump was very much pushing. The Act provides some temporary changes, not as sweeping as maybe campaign promises, but provides temporary changes to how tips and overtime are taxed for a specific window. This is from 2025 through 2028. And what it does is temporarily allow an above the line deduction of up to $25,000 for qualified tips. And then that deduction is phased out at higher incomes. And it also allows an above the line deduction for $12,500, and that's $2,500 for, $25,000 for a joint return for qualified overtime compensation. So some changes, not as sweeping as may have been earlier discussed. Next slide. So going back to child care and to paid family and medical leave, that subject generally. So under section of the Internal Revenue Code 45S, employers that provide paid family and medical leave can claim a tax credit. And the way it works is that it's a percentage of wages that the employer pays to employees while they're out on family and medical leave. And this originated in 2017 as part of the Tax Cuts and Jobs Act. The percentage of wages is 12.5%, and then it increases based on the amount paid to the qualifying employee that exceeds 50% of the employee's wages, up to a maximum of 25%. That's how the credit works. What the Act does is it makes this tax credit permanent because it was set to end, and enhances it also for taxable years beginning next year in 2026. It also allows for employers to claim the credit if they have a standalone insurance policy for paid family leave benefits, and that might be the case in particular for employers in certain states that where an insurance policy is required for state mandated paid leave benefits. And it also lowers the minimum employee work requirement in order for the employee to receive the credit from 1 year to 6 months. So essentially making it easier for employers to claim the credit in certain circumstances. So what do you need to claim the credit? And this is on the next slide. Employers have to have a written policy in place that provides at least 2 weeks of paid family and medical leave annually to all full-time employees. And then the paid leave has to equal at least 50% of the wages that the employee is normally paid. The tax credit is available to all employers in all states, but the amounts required under state law or paid for by the state in the states that have paid family and medical leave laws are not taken into account in determining the credit. So that's something to consider in designing your leave programs depending on where your operations occur. Another tax credit relating to childcare. This is for employer provided childcare. So another section of the Internal Revenue Code 45F allows employers to receive a non-refundable tax credit up to $150,000 per year based on 25% of qualified childcare expenses they provide to employees. You can think of this as like an on-site daycare center that some employers offer. The Act permanently increases the maximum credit. It also creates a separate credit amount for certain qualified small businesses and indexes the maximum credit amounts for inflation. So you can see here on the slide that the effective amounts paid or incurred after December 31st, 2025 for credits after that time, the maximum credit will increase from $150,000 to $500,000, and it's actually $600,000 for small businesses, with those dollar amounts being indexed for inflation. And then the percentage of qualified childcare expenses covered will also increase to 40% from 25%, and that's 50% for small businesses. The Act also allows small businesses to use a third-party intermediary to provide childcare services on their behalf. And there are quite a few services like that in the marketplace. Okay, so there are some other areas where we saw changes in the Act, and one in particular that's gotten a lot of press is the creation of so-called Trump accounts, as well as the changes related to the Affordable Care Act and its interaction with Medicaid. So I will turn back to Kathy to tell us more about these changes.
Thank you, Julia. The Trump accounts, and that is actually the name of the account in the statute, is available to children under age 18 who are U.S. citizens. The statutory language regarding creating these accounts changed a lot during the legislative process. And so I think there's a lot of conflicting information out there because some stories are summarizing what was in previous bills, and then some stories summarize what was actually in the bill that passed. So I do think that we're going to need quite a bit of guidance from the Treasury Department as to how these accounts work. But I'm going to give you a little summary of what we know. So beginning in January of 2026, the accounts are going to operate like individual retirement accounts that allow earnings to grow on a tax-free basis. The accounts have to be held by a financial institution, and they have to be invested in a qualified equity index fund like the S&P 500. They can't be, for example, in age-based portfolios like a 529 plan. Parents, relatives, and other entities can contribute up to $5,000 annually per child on an after-tax basis, and that amount is indexed for inflation, and they can contribute up to age 18. The account can receive tax-free contributions from certain entities like charities as well. So there's no withdrawals from the account permitted before age 18. After age 18, the account appears to be governed by IRA rules as to what kind of withdrawals you can make, but I think that's an area where we do need some clarification from the Treasury Department. It appears that any withdrawals based on investment earnings or tax-free employer contributions will be taxable as ordinary income, as long as it's used for a qualified IRA expense. An after-tax contribution would not be taxable when it's withdrawn. And the one thing that's gotten a lot of publicity is that children who are born from 2025 through 2028 will be automatically enrolled in the accounts and will receive a one-time deposit of $1,000 from the federal government into their account, which does not count against the $5,000. So as you can imagine, a lot of people are very interested in how this would work. We don't know exactly what that program is going to look like, whether the government would open the accounts or whether people would open the accounts and have the government fund them. Again, something we'll look forward to learning from the Treasury Department. So you want to move to the next slide, please. The reason that we're talking about these accounts today is that there is a new provision that allows employers to contribute to an employee's child's Trump account on a tax-free basis beginning in 2026. The employer has to have a separate written plan document to make those contributions, and the plan would be subject to non-discrimination testing under IRC Section 129, which is the DCAP rules that Julia mentioned, which can be pretty onerous and difficult for employers to meet. Employers can contribute up to $2,500 for each employee. It's not clear whether that's each child or just each employee, and that amount is indexed beginning in 2027. So employers are going to need to make a determination as to whether to fund these accounts, but they may find that there are more effective ways of compensating employees. For example, they may find that the non-discrimination rules are too constrictive for the accounts, or they may think that employees may be more interested in placing money into a more flexible account like a 529 plan. So this is going to be a very interesting process to get this guidance and to make this evaluation as to what kind of compensation arrangements these might create. So next slide. So as Julia mentioned, I want to talk just a little bit about the impact of the ACA and Medicaid cuts on plan benefits. So the Congressional Budget Office estimated that the health sector is going to lose $1.1 trillion as a result of the act, and that the act will result in more uninsured people in the year 2034 than would otherwise be the case, including 10 million more uninsured resulting from Medicaid changes and changes to the ACA exchange, and 5.1 million more uninsured because of the expiration of the enhanced premium tax cuts under the ACA exchanges. You may remember those enhanced premium subsidies, tax credits. Those enhanced tax credits or subsidies under the ACA exchanges were created during COVID to allow more people to have access into the exchanges. And they actually had the impact of increasing enrollment in the ACA marketplace from 11 million people in 2020 to 24 million people in 2025. So there's a concern that if those subsidies are cut back, and that would occur next year, then people who were going to buy coverage with the enhanced subsidies in the exchanges will forego that coverage. That results in coverage costing more for everybody in the exchanges and costing more for the individuals that purchase it in the exchanges. The estimates by some groups like Kaiser Family Foundation are that they're looking at the ACA premium amounts that are being filed in different states and finding that insurers in at least 20 markets are increasing premiums for exchange coverage by a median of 15%. And then the premium for an individual who's purchasing coverage in the exchange could increase as much as 75% next year. So what does that mean for group health plans? That means that if you were relying on exchanges to help provide coverage for some groups in your population, like retirees, or in some cases spouses, they may not be able to get that coverage in a cost-efficient way and may seek to come back into the employer plan. There's rules about special enrollment and how that works that you may need to become familiar with. So there may be more demands on the fund on the plan to provide additional coverage to those people who are going to lose coverage. In addition, the Medicaid cuts are going to occur basically in things like limiting state provider taxes, having work requirements for working age adults without disabilities or dependents, although most of those people are currently working, so the work requirements are going to be more reporting and record-keeping requirements, but could result in people losing coverage if they don't meet those record-keeping standards. The next slide. The act also includes a 5-year, $50 billion relief fund for rural hospitals and a Medicare reimbursement increase for physicians in 2026. So as I mentioned, group health plans could see increased requests for enrollments and requests for special enrollment as a result of these cuts. In addition, the cost impact on plans could be significant. Pretty much every day we're hearing about various pressures on the healthcare environment and healthcare providers. So we could see impacts on plans because providers may lose other sources of coverage, hospitals may lose sources of revenue, and may seek to recover that by imposing charges on other payers like group health plans. So we don't know exactly what those changes are going to look like in terms of cost shifting, but it's something to be aware of. I saw an article just today that hospitals may be focusing more on providing care through ambulatory services rather than hospital-based services. That could affect what kind of care your participants have access to. So we're going to see a lot of change in the healthcare marketplace, and it's important to be aware of that and keep an eye on that, on how it affects your health plan. So I think that wraps up our summary of the Act. And we wanted to talk a little bit about other things that are happening in the environment, including litigation. So I'm going to turn it over to Elena, who's going to tell you about some of the recent health plan litigation that's going on.
Thanks, Kathy. We can go ahead, into the slide. So a decision that we've really been tracking had been the Kennedy versus Braidwood Management case. That we've been tracking the case that ultimately led to the decision we can talk about here today. This was really inspired by opposition to the idea that non-grandfathered health plans would have to cover without cost sharing pre-exposure prophylaxis PrEP medications at no cost. And so when you think about the recommended ACA preventive services and where the requirements to cover those come from, they come from different sources, one of them being the United States Preventive Service Task Force. So there are other recommending task force related to things like child vaccines and things like that. And those were not implicated in this rule, but or in this case, but the task force, the US PSTF, was the task force that was being challenged. And the idea that was raised was that really this task force should have to have an appointee from the government, appointed by the president, confirmed by the Senate, running that, and that if it didn't operate that way, that it really wasn't a constitutional function. And the lower courts agreed with that, both the district court and the Court of Appeals. And so at that point, the administration did appeal to the United States Supreme Court, and the court did decide to hear the case. And so we saw the Trump administration file a brief in this case. We saw the oral arguments happen in April on this case. And we can go ahead to the next slide. Kind of during the oral arguments, we started to get the sense where the questioning was going, that perhaps there was a decent amount of merit being identified in terms of how the task force currently operates. On June 27th, the Supreme Court did reverse the Fifth Circuit decision, and basically agreed that HHS, that the way the task force functions is appropriate, that really the officers of the task force are inferior officers that do ultimately report to and are under the oversight of the Secretary of Health and Human Services. And they did kind of highlight the fact that technically the Secretary of Health and Human Services does have rights to do things like request that the task force reconsider a recommendation they've made, or ask that they withdraw a recommendation. So that's not really something we've seen actively occur in the past, but it was something, a right that the Secretary of HHS can advance that we did see highlighted in the decision. So we have seen that that's reversed. And so what does that mean for plans? Plans can continue to cover preventive benefits with no cost sharing in the same manner that they were currently doing. And I say currently doing because even though we had this litigation and even though plans were watching what might be the outgrowth of this litigation, we had also had communication from the federal departments encouraging plans to just continue to cover preventive services with no cost sharing, sort of at the status quo until this litigation played out. And that's what we did generally see plans doing. And here we are now where we've seen that there's ultimately no change, no impactful change. So plans will continue to look to those recommendations that come out of the task force. And normally if there's a new recommendation that comes out, then a plan has from the beginning of the next plan year from when that recommendation came out, sort of a whole plan year to implement that change and move forward with that. So we will watch if we ever see an instance where there's a request for a withdrawal or reconsideration, because of course then there would be time and considerations if plans were implementing changes pursuant to the task force. But that's kind of the update on that one. And I think we can go to the next slide. Another area where we continue to watch litigation relates to ERISA preemption. So we've had different things happening that we're watching and probably more things to come. The Mulready case, PCMA versus Mulready, was a case challenging a PBM law that was ultimately found to be preempted by ERISA. In the lower court, the argument had moved forward that perhaps this law was regulation of the PBM and not really the plan, but ultimately when the court really looked at it at the Supreme Court level, it determined it wasn't going to hear that case. And so it did stand that the decision that was ultimately made at the district court level that the law did in fact implicate the health plan and did not, couldn't be read as narrowly as just applied to the PBM, that law was found to be preempted, did hold at that district court level decision. And the U.S. Supreme Court had not agreed to hear it. And some of the things that came up in that specific state law that was challenged were practices like cutting off access to rural patient access, steering particular PBMs, pharmacy usage without sort of consideration for a network or for cost sharing incentives, exclusive pharmacy rights. So things like that were the different topics that were built within that case. Another case that we were watching was the McKee Foods Corporation. And this was a Tennessee court that ruled that portions of Tennessee law that regulated PBMs were preempted by ERISA to the extent the provisions apply to self-insured ERISA governed plans. So we have that. We have other cases percolating in Arkansas and in Iowa. So we see this continued tug between different state laws that are regulating PBMs and certain activities that they have and different challenges around whether or not they are preempted and whether they really relate to the administration of the self-funded ERISA plan. And so we'll continue to see how those lower court decisions are made and the splits that are being created and what at any point, whether the Supreme Court does hear any of these issues subsequently, but nothing currently pending a request to the Supreme Court. So I think that gives us a little update on the litigation, and we can move to the next slide. We're going to also talk about some other updates and topics to watch, and we can go ahead. So several things kind of fall in this bucket: ongoing political confirmations, preventive care changes, outgrowth of the executive orders that we saw issued early in the administration that may impact group health plans, MAPIA litigation, hot topics in Congress. So all of these things are things we're watching, and the three of us will kind of bounce around among these topics with some updates. I'm going to kick us off just for a minute talking a little bit about where we are with political confirmations. So we have, the Secretary of HHS and Dr. Oz heading up CMS in a confirmed situation. For the Department of Labor, the secretary is confirmed, but we are continuing to wait and expect that the Employee Benefit Security Administration leadership will be confirmed in the fall. Similarly, the Solicitor of Labor, who is another, significant representative who gets kind of involved in the strategy and the policy of the department, is also awaiting confirmation. So I think, for us, what we know that means is that while there are maybe acting leaders in place, maybe some, guidance that the agencies may be able to issue in a certain degree. We are still waiting for that true political leadership to take position, and sort of after that is normally when we start to see things like announcements of what will be the priorities of that administration, what might be their enforcement posture around certain things. So all of that are things we continue to wait to see how confirmed leadership really influences those processes. And with that, I'll turn it over to Julia, who I think is going to talk about some preventive care changes.
Yep. So going back to the preventive care topic in a way, because Elena just walked us through a few minutes ago the Supreme Court case that dealt specifically with the U.S. Preventive Services Task Force. We have a couple of other updates in terms of what we're watching as far as preventive care is concerned. There's been some turmoil in vaccine policy that you may have seen or heard about on the news. So in May 20th, the FDA commissioner, along with the director of the Center for Biologics Evaluation and Research, wrote that the FDA would limit access to COVID-19 vaccines going forward to people 65 and older, and others who are at a high risk of becoming seriously ill if infected. They also said then that the FDA will require manufacturers to conduct clinical trials to show whether the vaccines benefit healthy younger adults and children. So then a few days later, on May 27th, the HHS, Health and Human Services Secretary, Robert F. Kennedy Jr., announced on X today, and I'm quoting from the announcement, today the COVID vaccine for healthy children and healthy pregnant women has been removed from @cdc.gov recommended immunization schedule. Bottom line, it's common sense and good science. We are now one step closer to realizing POTUS's promise to make America healthy again. So we saw this announcement, but it wasn't clear what the actual change was going to be to the vaccine schedule. 2 days later, on May 29th, we got CDC guidance that instead of recommending that, by the CDC recommendation, the COVID vaccine for kids 6 months through 17 years of age, the CDC is now recommending vaccination based on shared clinical decision making. So essentially a conversation with a provider about the vaccine. Plans at the moment should still pay for COVID vaccines for all adult women and for children for whom the vaccine is recommended by their provider. Of course, they can do so even if they're not required to do so. But right now, given all of the uncertainty, plans should still see this as a requirement. And if future substantive changes occur, and would allow for plans not to provide that coverage, the plan would still have to continue the coverage through the end of the plan year. I'd also mentioned that the U.S. Preventive Services Task Force that Elena referenced in talking about the Supreme Court decision, its most recent meeting has been canceled. It was canceled abruptly. It was July 9th, so earlier this month. It was supposed to meet later this month, and on July 9th, there was an announcement that the meeting had been postponed, and no new meeting date is set. So as you can see, this area is very much in flux and very much a piece of the political picture right now. So one change that's a lot more definitive, it concerns the women's preventive services benefits and some guidance about breast cancer screening. So the ACA's Preventive Services Task Force and the preventive service requirements mandate that non-grandfathered group health plans and insurers cover certain preventive services on a cost share with no cost sharing on an in-network basis. And the Preventive Services Task Force that Elena mentioned is one of the entities that provides the information and updates on which services have to be provided with no cost on an in-network basis. There are some other entities, including HRSA, which has guidelines regarding the preventive care and screening for infants, children, adolescents, and women. So previous HRSA guidelines had recommended that women who have an average risk of developing breast cancer start mammogram screening no earlier than age 40 and no later than age 50, and that screening occur at least biennially and as frequently as annually and continue through age 74. The guidelines were updated because the regulators were seeing some questions and complaints come in from people who had had their initial mammogram and then were referred to for imaging as a result of the results of that initial mammogram, and then were being charged cost sharing. And that's not how it's supposed to work, according to HRSA. So now we have updated guidelines that provide that the additional imaging requirements that are part of the screening process also have to be covered on an in-network basis without cost sharing. So that means both the initial mammography plus any additional imaging, such as an MRI, an ultrasound, or additional mammography, as well as pathology evaluation if that's required to complete the screening process for malignancies. This begins in 2026 and is consistent with other types of preventive care guidelines, such as colon cancer screening, that essentially require that the screening be a robust screening that includes any follow-up for issues that arise in the initial scan, and that all of that should be provided on an in-network basis without any cost sharing. Now, shifting gears a bit, we mentioned that one of the topics we've been watching is are the developments from the various executive orders that have been issued. And for anybody who was paying attention at the beginning of this administration and continues to this day, there have been a ton of executive orders. And naturally, some of those executive orders relate to issues that may affect or do affect group health plans. So I'll turn to Kathy to tell us a bit about some of those executive orders, what's happened pursuant to them, and what we should be watching for.
Thank you, Julia. We're going to go through these rather quickly, but we do have publications on our website discussing all of these executive orders. The President's Make America Healthy Again Commission came out with its initial report in May, and we're looking for a final strategy report in August. I'll talk about that in a little more in a second. We got an executive order on expanding access to in vitro fertilization, which had promised some recommendations. Unfortunately, nothing has been released further on that issue. Next slide. We have an executive order on transparency, empowering patients with pricing information that I'll talk about in a second. And then several executive orders on drug prices, lowering drug prices by once again putting Americans first, and delivering most favored nation prescription drug pricing to American patients. Next slide. So on the Make America Healthy Again Commission, the MAHA May report focused on drivers of childhood chronic disease, particularly the shift to ultra-processed foods, the cumulative load of chemicals in our environment, the crisis of childhood behavior in the digital age, and the over-medicalization of our kids. So these are the areas where we can expect to see the next report coming out in August dig in and focus on strategic changes, perhaps like on the last one, the growth of the childhood vaccine schedule. We may see strategic changes recommending changes to the vaccine schedule or to medications. We've already seen them looking at things like ADHD medication. So it'll be very illustrative to see this report, to see where the priorities of the administration are going to focus. So next slide. I mentioned a couple of transparency issues. In response to the executive order, the administration issued a request for information on prescription drug machine readable files, an FAQ on transparency rules, and changes to the hospital transparency rules. The next slide. The RFI regarding prescription drug machine readable files indicated that the departments are going to now require that in addition to the 2 machine readable files you have to have now on in-network fees and out-of-network costs, they will start implementing that prescription drug machine readable file, but they're looking for information on how to technically do that, and that's what the RFI was about. The next slide. With regard to those 2 files that I mentioned, the in-network claim and the out-of-network allowed amount machine readable files, the departments have indicated that they are going to update the schema for those files, and that the updated schema is going to be released on October 1st, and then plans will have 4 months to complete updates with a compliance deadline of February 2nd. Now, most of you have your service providers or your carriers doing these files for you and sometimes even hosting it on their website. So it will mean that you'll just need to make sure that your carriers are updating the files accordingly. So next slide. I'm going to turn it over to Elena now to update us on mental health parity litigation.
Thank you, Kathy. And just to give folks a little bit of a quick background of how we got to the litigation phase, we had those longstanding 2013 final MAPIA regulations. At the end of 2020, we had a statutory amendment to MAPIA. This is where you saw things like the requirements for plans to have a documented comparative analysis, added to the statutory requirements of MAPIA, and those became applicable in early 2021. Plans operated for a long period of time in an absence of guidance. There was a federal FAQ out there that was issued soon after the statute was amended. And then we were really waiting for guidance for a long time. In 2023, in August, there was a proposed rule issued, and that raised a lot of concerns and inspired a lot of comments from the regulated community. The government received over 9,500 comment letters with respect to that proposed rule. The result was a slightly revised, but not dramatically changed final regulation that was published on September 23rd, 2024, which included staggered applicability dates for 1/1/25 and 1/1/26. There were many issues related to the requirements in those, including the fact that some of the requirements were not expressly in the statute. And so, really drove what led to the ERISA Industry Committee filing litigation challenging that final regulation, raising claims that the government had ultimately violated the due process clause of the Fifth Amendment and also acted arbitrary and capriciously and otherwise violated the APA, both in some of the expansive nature of some of the provisions of the final rule, as well as in the timelines. So we had the court, we had the federal departments ask the court for an abeyance, and we can go ahead to the next slide. That abeyance was granted, and that is while the departments continue to reconsider and review the final regulation. Meanwhile, they did make a statement of enforcement. So again, it's a statement of enforcement, not a non-enforcement policy, because the statutory provisions of that 2013 final regulation remain in effect and enforceable. It's just the new things that were under that final rule that would have become applicable in 1/1/25 or 1/1/26. Those newer provisions are not going to be enforced at this time and won't be until a final decision in the litigation plus 18 months. So that kind of gives us a cap on the MAPIA litigation. And then we have just a couple moments. I'll turn it over to Kathy at the next slide, where we talk about the last hot topics that we're tracking.
Yeah, we always get asked about what's coming next, and a few things are coming. The Senate was considering hearings and new potential legislation on unlocking benefits for independent workers. So there were several laws that would have expanded association health plans, made pensions available to independent workers, and changed the Fair Labor Standards Act definition of employer and employee. There was a hearing on those bills, but there's no current action on them, but we do expect that it's going to still be coming up. In addition, prescription drug reform is always going to be an issue. There was a bill that would have passed at the end of 2024 that would have significantly changed PBM regulation. That did not end up going through, but that bill is still out there. It still has bipartisan support, and we may see that coming up if there's a vehicle that it can be attached to. In addition, HSAs may continue to be a subject of discussion, particularly since we do have the model for expanding HSAs that was in the House bill. So I wouldn't be surprised if that also gets attached to some other legislation. And then finally, there was a hearing in the House on restoring trust, enhancing transparency and oversight at EBSA, where House members were quite critical of some of the policies and procedures of the Employee Benefits Security Administration and may seek to make some changes in a variety of aspects of how that administration is run. Once we get a new EBSA head in, we could see some significant changes. So with that, I'm going to turn it back over to Jason, and he's going to close us out.
Thank you, Kathy. I know that there were a few questions that were asked in the chat that I believe you were able to address. If you asked a question that we did not address live, we will definitely follow up with you individually. Special thank you to all of those who attended the session and to today's presenter. Please have a great day. This concludes today's webinar. Thank you.